Type 2 diabetes and obesity drives significant morbidity, mortality, and healthcare costs in the United States. Clinicians, most often primary care physicians, are increasingly prescribing GLP-1 receptor agonists as well as combination medications with GIP-1 to treat these and many other conditions. While these medications are effective, they have been associated with both benign but also potentially life-threatening complications impacting the gastrointestinal tract and accessory organs. The management of these medications prior to endoscopy can be quite nuanced. Hi, my name is Vivek Saha, and I'm a former internal medicine resident physician at Mayo Clinic, Rochester, and graduate of the program. On behalf of my colleagues and my mentor, Dr. Kottapilli, I'm delighted to talk about our recent paper titled GLP-1 and GIP receptor agonists, effects on the gastrointestinal tract and management strategies for primary care physicians. We are pleased that it will be appearing in the December 2025 issue in Mayo Clinic Proceedings. In this setting, we present a comprehensive but concise review of the clinical impacts of GLP-1 receptor agonists and combination with GIP, so incretin-based medications on the GI tract, while providing a framework for the management and preventative strategies for primary care physicians. So in this review, we synthesized the latest data on how these powerful medications impact the GI tract. First, we detailed the common side effects: nausea, vomiting, diarrhea, and constipation. We emphasize that these are typically mild to moderate and often transient, improving after the maintenance dose is reached. We also reviewed more serious, although less common complications. The data shows a clear increased risk for biliary diseases like cholelithiasis and cholecystitis. However, regarding acute pancreatitis, we found that higher quality studies, including meta-analyses, do not show a significant increased risk, which should be reassuring, of course, both to the clinicians and our patients. A major focus of our paper is the impact on endoscopy. For upper endoscopy or EGD, patients on these drugs do have a higher risk for retained gastric contents, but importantly, this does not appear to translate to a higher risk for aspiration. However, these medications may have a higher rate of aborted procedures and the need for repeat procedures because of this. For colonoscopy, there is an increased risk for inadequate bowel preparation with incretin-based medications. This increased risk of inadequate bowel prep likely stems from constipating effects of GLP-1 receptor agonists or possibly due to delayed exposure time of the bowel prep medications with the colon secondary to slow gastric and small intestinal motility. Now, for capsule endoscopy, there is some data suggesting greater gastric transit time, as well as higher rate of incomplete small bowel passage. So how does this translate to clinical practice, and what does this mean for our patients? So this is where our findings become a critical tool for primary care physicians, both for managing new procedural questions and for day-to-day life patient care. So our clinical algorithm in Figure 1 is designed to guide this entire process, essentially. So for day-to-day symptom management, this is essential for patient adherence and quality of life, of course. It starts with proactive counseling. We must tell patients to expect GI side effects, but also reassure them that these are typically transient and mild to moderate in severity. The first line management is dietary modification. We advise patients to eat smaller, more frequent meals, eat slowly, and avoid high-fat or sugary foods. Adequate hydration is, of course, also very crucial. If symptoms do persist, the next step isn't stopping the medication, rather it's halting dose escalation. We should maintain the current dose for another 2 to 4 weeks before reassessing. For refractory symptoms, we can offer targeted short-term medications such as antiemetics, prokinetics, or antidiarrheal agents, depending on the symptom, of course, at the lowest effective dose. Discontinuation is reserved for absolute intolerability, severe symptoms related to delayed gastric emptying, or pancreatitis. So for endoscopic management now, or pre-procedural management, this is where the guidance really has evolved. Historically, there was significant concern about aspiration risk, as you may imagine, for EGDs. Early expert opinion-based guidelines recommended holding these medications before any elective procedure. This created a lot of confusion, perhaps even risk, particularly for our patients with diabetes who could then experience perhaps hyperglycemia. Our review highlights the new multi-society consensus guidelines that now recommend a more individualized approach based on shared decision-making. That is, for EGDs, the new guidance moves away from a blanket hold recommendation. Rather, for patients without risk factors for retained gastric contents, the medication can simply be continued. For patients with risk factors, including being on longer acting agents, higher doses, or in the dose escalation phase, or GI symptoms associated with delayed gastric emptying, or comorbidities that could delay gastric emptying, like Parkinson's disease, these medications can be continued, but the patient should be on a liquid diet for at least 24 hours prior to the procedure. And finally, patients that are considered to have a high-risk profile, the consideration of holding the GLP-1 medication should involve a multidisciplinary discussion involving the risk and benefits of this action. Now, for colonoscopy and video capsule endoscopy, the challenge here is more so procedural quality and completion, respectively. Importantly, many current guidelines appear to make suggestions regarding EGDs, but explicit recommendations regarding colonoscopy and specialized endoscopy are scarce. However, based on our review and the data we have assessed, given the high risk of inadequate bowel preparation for colonoscopy and incomplete passage for video capsule endoscopy, we recommend possibly holding incretin-based medications based on the current data that's available, especially for optimal evaluation. So what is the next step? So looking ahead, future research is warranted regarding the management of these medications prior to especially colonoscopy and specialty endoscopy. Indeed, we anticipate the fluidity in the guidelines as new evidence emerges. So this review was written for busy primary care physicians, and we hope it serves as a practical clinical tool for you and your patients. With that, I would like to invite everyone to read our article and publish in Mayo Clinic Proceedings in December 2025. And please do not hesitate to reach out with any questions. Thank you.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com/Mayo Proceedings, or journal updates on Facebook, www.facebook.com/Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.